that respiratory infections are among the main reason behind medical consultation. And every medical consultation and every illness produces loss of productivity. By far, 60% of them are receiving antimicrobials. We have to understand that common cold, laryngitis, pharyngitis, tonsillitis, sinusitis, otitis are among the most common clinical cases which we deal on our OPD practice. So also bronchitis, bronchiolitis, pneumonias, tracheitis are among the most common reasons of lower respiratory infection which we deal in our OPD practice. So let's begin. So to understand, in the current practice, the 5 most common reasons for antimicrobial drug use are non-specific respiratory infections, pharyngitis, otitis media, sinusitis, bronchitis. Since these 5 are the main reasons, I have picked up the topic where I'll be dealing with these 5 respiratory infections. Most of them do not require antimicrobials, and those few which require antimicrobials, I'll be dealing today. So first of all, sinusitis. I think invariably lot of us come across patients which have running nose. Yet these running nose patients do not require any antibiotic therapy. But there are few patients who will warrant an antibiotic therapy. So let's try to understand who these patients are. Now, as you can see in the picture, there are 4 sinuses. The one at the top is the frontal sinus. The one between your eyes are the ethmoid. One at the maxilla, the maxillary sinus, and those behind are the sphenoid sinus. So, acute sinusitis. Most commonly, sinus infections are predominantly viral in origin. Viral infections do not require antibiotics. Second, most commonly they are allergic in nature. So, a lot of allergics don't require antibiotic therapy. The other features which may cause these infections are smoke, maybe a cigarette or household smoke, kids who are involved in swimming, adults who go into depths or to high altitude. These are all risk factors for sinusitis. Please try to understand. Of the sinusitis, 90% are viral in origin. Yet, there are few which are bacterial in origin, and these have to be identified. So, we will focus this topic on identifying these bacterial origin sinusitis. So, first of all, which are the most common bacteria? So, strep pneumoniae, Haemophilus influenza, Moraxella catarrhalis, and Staph aureus. These are the most common bacteria which can cause sinusitis. Now, as we all know, most of them are viral in origin, but few can be bacterial in origin. Now, why do bacteria cause sinusitis? Please understand. Invariably, what happens is whenever you have a cold, we tend to blow our nose rapidly. When we do so, sufficient force is produced in the sufficient force is produced, which causes the bacteria to enter the sinuses. Normally, what happens is these bacteria are rapidly cleared by the mucociliary clearance in the sinuses. But whenever there is a viral infection, there is impairment to the mucociliary clearance. So also there is edema. Edema causes swelling, which leads to blockage of the ducts, which allows the bacteria to grow in this enclosed cavity. Once this happens, then there is what we call as bacterial sinusitis. Now, having understood this, let's try to focus on how do we diagnose a bacterial sinusitis. Please focus, this is very important. If the symptoms of sinusitis persist or despite your treatment don't improve for a duration of 10 days. So sinusitis cannot be diagnosed at a very early onset. Make sure if it goes beyond 10 days. Sometimes there is a phenomenon called as double sickening. That is, you usually see that some kid will come to you with a runny nose. This goes on for a duration of 3 to 4 days and he's fine. And suddenly after 2-3 days, there is worsening. He comes with more high grade fever and the secretions from the nose become purulent in nature. This is called as double sickening. That is, there is new onset symptoms or worsening of the old symptoms. Occasionally, if there is very high fever at the beginning with severe facial pain or purulent nasal discharge, and if this continues for the next 3 to 4 days, then we can definitely consider bacterial sinusitis. So we have to understand most sinusitis are viral. Occasionally, it can be complicated, or there can be a primary bacterial sinusitis. So if we are able to diagnose this, then we are allowed to treat it with antibacterial. Now, this is the flow chart through which I'll try to make you understand the right method in approaching sinusitis. First of all, we understood what are the signs and symptoms if there is presence of risk factors. So what are the risk factors? Say if a child is very young, less than 2 years, or a very old person, if he has been hospitalized recently, he has some comorbidities in the form of he is a case of HIV, he has immunocompromise, he is a case of tuberculosis, or he has received stem cell transplantation, he is a case of leukemia, or he is hospitalized just before initiating of this therapy, say in the last 5 days, or he has already received antibiotics in the last month. In such a condition, we consider this as a high risk factor. If none of them are there, we'll consider it as a low risk factor. If it is low risk, then we put him into the category of mild to moderate severity. In such a child, what you do is you initiate therapy with amoxicillin. Amoxicillin is the drug of choice for sinusitis. The dose is 30 to 40 mg in 2 to 3 divided doses. Now, what is the ideal way? As you begin therapy, you advise the patient to come back to you after 3 to 5 days. If you see that he is doing well, excellent. Please continue the course and finish it for the next 7 days. Ideally, what happens in kids is the bottle is 30 ml, usually gets over by 3 to 4 days. Ask them to come back, give another bottle and send. So he has to complete the course of 5 to 7 days. This is essential to treat any bacterial infection. If this is not going according to plan, or he is a child with risk factors, then what is supposed to do is group him into part 2, that is severe disease or no response to treatment. Then the ideal choice is co-amoxiclav. Now, please focus. The dose is 80 to 90 mg in 2 to 3 divided doses. Unlike a mild infection where you give for 30 to 40 mg, in a severe infection, you give a higher dose. And again, you call him back after 3 to 5 days. If he is improving, now our course goes on for 7 to 10 days. Sometimes what is noted is some children do not take the oral antibiotic, or they have associated vomiting, or they are very sick. In such a condition, IV ceftriaxone at a dose of 75 mg is permitted. If improves in the next 7 to 10 days, very well. If it is not improving, then we have to consider that is there any complication. There are a lot of complications of sinusitis where the bacteria can go intracranially. There can be cavernous sinus thrombosis, Pott's Puffy tumor, or there can be purulent discharge, which might require surgical approach. So these are the main treatment guidelines for sinusitis. Occasionally, if the patient is allergic to penicillin, then we can consider Leoflox or Moxiflox, or if it is non-type 1 allergy, then cefpodoxime, cefuroxime, and ceftinir are drug of choice. Now let's focus on the topic at hand. If in case of acute sinusitis, is there a role for clarithromycin? Definitely yes. So as per the guidelines, if the patient is allergic to penicillin, the drug of choice is clarithromycin and doxycycline. So also, in case he has received an antibiotic therapy just before, or he has been frequently receiving amoxicillin, or he has had a side effect with amoxicillin, please do consider the use of clarithromycin. What is seen is Du Bois et al. Made a study to see the efficacy and safety. They found out that the bacteriological cure is comparable. That is, 87% responded to clarithromycin while 90% responded to amoxiclav, which is almost similar. While adverse effects were less common in clarithromycin, and there was less common incidence of GI symptoms. So clarithromycin is safe and has equal efficacy. So in such a child with sinusitis, you can consider clarithromycin therapy. To summarize, Please understand, most of them are viral. Strep, staph, moraxella, H. influenza are most common bacteria. Amoxicillin and amoxicillin is the drug of choice. Clarithromycin is your second option, or clarithromycin is the drug when there is side effects to amoxicillin. So through this, we understood how to deal with the case of sinusitis. The next most common infection which we see in OPDs is a case of pharyngitis or tonsillitis. Now, please understand, again like sinusitis, most pharyngitis and tonsillitis are viral in origin. There are 80% of them which are viral, while there are few which are bacterial in origin. But the ones which are bacterial are severe than the virals. Group B streptococcus are the most common cause of bacterial pharyngitis. It is very commonly seen in children less than 5 years. The other bacteria known are Schlemidia, Mycoplasma, Haemophilus, Corynebacterium diphtheriae. Now, how about tonsillitis? So many times tonsillitis can be a part of pharyngitis or it can come isolated. Now, what you can see is invariably all tonsillitis receive antibacterial therapy, but again, most tonsillitis are again viral. Occasionally, bacterial tonsillitis can complicate viral tonsillitis. The most common cause is Epstein-Barr virus. Again, beta-amyloid streptococcus are very commonly known to cause tonsillitis. Please understand, those who are having group B hemolytic streptococcus as an infection for the tonsillitis, they can complicate to either a rheumatic fever or a glomerulonephritis. So, treatment of identifying a bacterial pharyngitis and tonsillitis is paramount. Now, how do we identify? So these are some of the signs which have some predictive value. Like if you have a watery nasal discharge, likely to be viral. There is no pharyngeal erythema, likely to be viral. A very good sign is presence of lymphadenopathy. A tender lymph node usually suggests a bacterial. Now, please try to understand, these are only suggestive things. You cannot take it as a whole. If all of them are present, the predictive value is better. Single sign is not definitive. So how does a viral pharyngitis and a bacterial pharyngitis present to you? Usually viral pharyngitis presents as a diffuse infection of a child will have a red eye, a rhinorrhea, a cough, a diarrhea, skin rash, all of these. But the pharyngeal exudates and lymphadenopathy are less common. While if it is bacterial, then it is explosive onset. The patient has severe throat pain. He has very little or no cough. It progresses rapidly. He'll have thick exudates or ulcers or vesicles or patch on the tonsil. And there is a tender lymphadenopathy. Patient is toxic. So if these are there, it is more likely to be bacterial. While if there is no node, there is no patch, it is more likely to be viral in origin. So treatment of pharyngitis or tonsillitis predominantly in adults is treated with a dose of again amoxicillin and clavulanate, but there is role for macrolides where macrolides can be given at a dose of 250 mg for 5 days. How about children? Most of the time children are again receiving penicillins or amoxicillin. Again, the second choice, if there is penicillin allergy, then you have to go for macrolides. So what we understand is newer macrolides such as clarithromycin and azithromycin have better safety profile, and clarithromycin dosing is twice daily as in adults as well as in children. So this is the dosing pattern. So what you can see is it is available as 250 mg and 125 mg. For less than 10 kgs, you can use half the dose. For 10 to 20 kgs, 125 mg is suitable. For beyond 30 kgs, 250 mg is the right choice. So when they compare the efficacy of penicillin and clarithromycin, it was found out that resolution was almost equal. Bacterial cure was higher in patients with clarithromycin than penicillin, 95%. So what is seen is both of them have similar safety profile. The clarithromycin has a better safety profile. Treatment options are similar. So when they compared clarithromycin and azithromycin, it is found that clinical cure was almost similar. Bacterial eradication again similar, but reinfection was less among clarithromycin, and adverse events were almost similar. So to understand, how do you deal with it? So whenever you are dealing with a child with a throat pain, you examine the eye, ear, nose, and the body. All of them are showing some signs. High likelihood that it is viral in origin. Give treatment for 3 to 4 days. Most of the time it will respond. If it is not responding, check out for the nodes and the patch. If any of them are there, it is definitely bacterial. Treat with antibiotic. If in the first situation, if it did not respond, then you have to go for rapid antigen detection testing. That is, you can do a swab, and if it is positive, you have to treat. If not, you can follow. So this is the right protocol. Now, to summarize pharyngitis tonsillitis, this is again mostly viral in origin. A lot of bacteria are known to cause pharyngitis. Penicillins are the first choice. Clarithromycin is the second alternative, and it has good safety profile and good eradication profile. So choose clarithromycin if you are not happy with the first choice. Now, very commonly asked question is, should we go for a tonsillectomy? Now, try to understand that the guidelines are, if there are 7 episodes in 1 year, or in the 2 years, there are 5 episodes per year. So that is 10 episodes in 2 years, or tonsils are so much enlarged that it is causing upper airway obstruction, or there is an abscess in the tonsil. So these are the conditions where you have to go for tonsillectomy. Not all patients with having a tonsils need to be removed. Large tonsils like this, yet there is no obstruction, then no intervention is required. It will come down by itself. Another very important topic is otitis media. So many times what happens is, since we do not have an otoscope, we are not able to properly diagnose. Yet clinically we can find out some clues. So through this, I'll try to explain how to treat otitis media with an antibiotic. It is seen that 80% of children suffer with otitis media. As in my practice, invariably, if a child is excessively crying, the first thing I check is his ear. That is so common. Most of the children whom there is a pain in the ear, possibility of otitis should be considered. As again, all the bacteria which are there for sinusitis and pharyngitis are also the most common bacteria for otitis, that is strep, haemophilus, and moraxella. Now, what are the primary features? In children, what you see is usually there is an upper respiratory infection. The child has a cold cough, following which there is blocking of the ear tubes and fluid accumulates in the ear. Now, the child comes with fever, irritability. Please understand, at this time, child might have diarrhea and vomiting. Now, this is something called as parenteral diarrhea. Sometimes diarrhea is because of the infection of the gut, while in some conditions, it is because of the viral infections or bacterial infections which are beyond the gut. Such conditions are called as parenteral diarrheas. So in such a child, there can be a diarrhea and vomiting. And if you examine the tympanic membrane, it is red, bulging. This gives you the diagnosis of acute otitis media. While in adults, they usually come with complaint of ear pain, they have a sore throat, they have decreased hearing. Adults, since they can tell, they come to you quite early because they can identify it. So many times they may have to undergo tonsillectomy and adenectomy. So this is how a difference between adults and children. So when do you give antibacterial to a child with otitis media? So since it is a thing which you cannot easily diagnose, these are the guidelines prescribed by B. So what is mentioned is, he's a child less than 2 years, be a little bit more allowed and start antibiotic early. Say there is otorrhea, there is unilateral or bilateral otitis media, and there are severe symptoms. Severe symptoms are high grade fever, lethargy, or even if there is no discharge but it is bilateral, start antibiotic therapy. If it is only unilateral, you can wait for some time and observe with conservative management. But if it is beyond 2 years, if there is no discharge and symptoms are not severe, no antibiotic therapy. Only if there is discharge, only 1 year also, both years, no problem. And if there are severe symptoms, start antibiotic therapy. But no severe symptoms, no discharge, you have to treat it conservatively. So, what are the steps in management? Predominantly, the treatment is with analgesics. You have to give paracetamol. So many times, ibuprofen or bifenamic acid is given, but it was identified that it has almost equal efficacy. There is no role for decongestants. Now, please focus. Since it is an enclosed space, antibiotics in divided doses for at least 10 days. So what you understood was, even for sinusitis 10 days, for pharyngitis or tonsillitis if it is bacterial 10 days, again for otitis it is 10 days. So whenever you are dealing with a patient whom you have confirmed a case of bacterial infection, you have to aim at eradication. So there is no role for 3-day antibiotic, 5-day antibiotics, 2 tablets of antibiotic, there is no role for that. Amoxiclav again is the first choice. Now, if in such a case you have waited for the next 72 hours, you are yet continuing the therapy for the next 10 days. If the patient deteriorates in the first 3 days, then you have a choice of increasing and going to ceftriaxone. So the recommended guidelines are, if the patient is allergic to penicillin, then you have to go with clarithromycin as the next choice. So again here, the dosage for amoxicillin is 80 to 90 mg, which is a higher dosage. Unlike for regular infections where you use 40 mg, here you are using a high dose amoxicillin therapy. Again, like previous slide, the dosage of clarithromycin is mentioned. So an easy way is based on 10, 20, 30 kgs. Now, they've identified what is the efficacy of clarithromycin over amoxicillin. The clinical cure was comparable. Adverse events were lower in clarithromycin. Drug-induced diarrhea was higher with amoxicillin. So, please understand, to summarize, most of the otitis are viral in origin. Again, these are the most common bacteria: staph, streptococcus, influenza, and moraxella. Clarithromycin is recommended first-line agent in treatment of otitis media in patients who are allergic to penicillin or its derivatives. And clarithromycin is safe as compared to amoxicillin and has equal efficacy. Another very common reason to treat patient in your OPD is pertussis. Now, invariably, all the doctors must have faced this case where a child keeps on coughing for very long duration, and you have tried a lot of therapies and it is not working. It is also called as 100-day cough because it goes on for a very long duration. For diagnosis, at least the cough should be there for 2 weeks, with or without a whoop or post-test vomiting. A whoop or post-test vomiting is a clincher, but this is not absolute criteria. And so many times we have all received the vaccine of DPT. P is for pertussis, yet it is not 100% efficacious. So even if the child has received pertussis vaccine, still pertussis can be common. Now, another first sign to identify pertussis is complications. Like, since the person coughs for a very long time, very severely, he can have a congenital hemorrhage. He can have a rectal prolapse. Some patients have even had fractures and encephalopathy. So it is one of the most dangerous coughs. Now, how do you identify a paroxysm of pertussis? Typically, it is rapid, forced expiration followed by a gasp. Sometimes so much so that the patient can have cyanosis, bulging of eyes, tongue protrusion, salivation, neck veins are engorged. He might even vomit post his after his cough. several times in a day, even at night. Occasionally, this is triggered by a simple yawn or a simple sneeze or just lifting some physical exercise. Whoop and post-tussive vomiting components of paroxysm are not essential for everybody, but they are the clinching signs. So I'll try to show a video where you can identify pertussis. So this is a person with pertussis.
Hello.
Yeah.
So we are not able to see a video.
Oh, is it
Yeah.
now?
You will have to minimize the presentation.
Okay. Now?
No, no, no.
Is it now?
No, sir. So you minimize your presentation.
I
Or
have
else,
minimized the present.
okay. But we are not able to see.
Okay, fine.
The
It's
only
okay.
thing we see is your presentation here.
No problem. So this is not that was not very important. Anyways, so usually the patient coughs for a long duration, and there is a post-tussive woof. I'll try to simulate it. If you can hear me, so usually it presents as a cough, something similar to this. So this is how usually a patient with pertussis coughs. Were you able to hear me?
Yes, sir. We were able to.
So when there is a post-tussive whoop, that is the classical presentation of pertussis. Now, clinically, how can we identify the absolute rise in lymphocyte count? Lymphocyte counts are usually elevated. So this is the classical finding, but so many times it is normal. The chest X-ray is non-specific. Cultures have no role. PCR are not recommended. So usually clinical diagnosis is what is paramount. Having understood this, the treatment of pertussis is mainly focusing on antibiotic therapy in the first week. So the drug of choice are macrolides and cotrimoxazole. So clarithromycin, in my experience, has had a very good role in treating pertussoid type of cough. The other measures like gentle suction of secretions, avoidance of cough-provoking factors, some humidified oxygen have all benefited my patients. But invariably, we have seen that so many patients are receiving antihistaminics, steroids, salbutamol. They have no role. It's not a bronchoconstriction, or it is not a allergy. So steroids and salbutamol have no role in pertussis type of cough. Now, coming to the next difficult topic is atypical community acquired pneumonias. Try to understand. First, we have to understand what is the community acquired pneumonia. So, community acquired pneumonia is an acute infection of the pulmonary parenchyma in a previously healthy child. He should be outside of a hospital setting. So, that is, in the last 14 days, he's not in the hospital, or at least he has not been hospitalized less than 4 days prior to onset of symptoms. So, it is acquired in the community. So, this is a community acquired pneumonia. So, usually pneumonias or atypical pneumonias. So, first of all, we have to understand how do we clinically identify these things. So, the first thing is most of them can be because of viruses, bacteria, chlamydia, or can be of mixed in origin. Now, basically, the child presents with cough, rapid breathing, and difficulty in breathing. Now, there are few differentials which you have to identify initially, that is, to identify clinically. If it is in a very young child, that is less than a year old, with associated upper respiratory infection like a nasal discharge or erythema of the nose, with progressive increase in respiratory distress, the V's or crackles are plus or minus, and a chest X shows hyperinflation. In such a condition, our first diagnosis will be bronchiolitis. See, focus. There is less fever in this child. The child is comfortable but having rapid breathing. Now, the second differential will be a barking sort of cough, wherein the the patient will be having something like a sounds of breathing, which is more sounding like a barking or brassy cough, or you might even consider it to be a stridor. There is marked respiratory distress. There is sonorous bronchi when you are auscultating, but the fever is very mild. So this is a classical croup. Now, if the patient has recurrent episodes, there is a family history, the allergic predisposition is there, a typical wheeze with a good response to bronchodilator therapy, then you consider asthma. Now, having ruled out all these things, then we come to a diagnosis of atypical community acquired pneumonias. So these are predominantly caused by mycoplasma, Schlemidia, and Legionella. So these are what are conditions called as atypical community acquired pneumonias. Please focus, there are very few differentiating factors while identifying these illness. So the most common is mycoplasma, which is cause for atypical pneumonias. Now, if your patient has a pneumonia, feature of pneumonia with tachypnea, rapid breathing, cough, hurried breathing, with diarrhea, with earache, with lot of myalgia, headache, with a sore throat. So all of them are pointing towards possibility of a viral bronchitis. If such a thing is there and it is complicating, like he has a confusion, so or he has a pleuritic chest pain, so these will point towards a diagnosis of possible mycoplasma pneumonia. Usually what we tell is atypical pneumonias are cough predominant pneumonias. Similarly, if again there is a lot of myalgias with respiratory infection, you have done a diagnosis of pneumonia, chest x-ray is symptoms are more, signs are less, then we have to consider these variants of pneumonia. So this is slightly complex, yet we can think of this as a cough pneumonia. Chest x-ray is not showing many features. There is associated viral like prodrome or symptoms persisting during a bacterial pneumonia like condition. Then we consider atypical pneumonias. So the pneumonias usually treated with amoxicillin, amoxiclav, then you can go for ceftriaxone, not responding ceftazidime, then you go for meropenem. But atypical pneumonias do not respond to these drugs. Atypical pneumonias are resistant to beta-lactams. This is because mycoplasma, legionella, and these are lacking the cell wall. Beta-lactams destroy cell wall, so the mycoplasma will not respond to your beta-lactam drugs. Now, these will unnecessarily cause a lot of side effects. But even if you're using drugs like fluoroquinolones, like your moxifloxacin, these have some side effects, especially in children with what is called as tendinitis, or doxycycline can cause dental erosions. The IAP has put a guidelines that fluoroquinolones should be considered as reserved drugs for tuberculosis. So we should, as much as possible, avoid respiratory fluoroquinolones. So in this condition, the drug which comes to our rescue is usually clarithromycin. So at the end of this, I'll try to focus on what are the advantages and how clarithromycin gives various roles and how it provides efficacious clearance of the bacteria. Please understand, clarithromycin is a broad spectrum antibacterial. It is very effective in against atypical pathogens. The resistance is less common with clarithromycin. It produces what is called as pneumolysins, even at subminimal inhibitory concentration. It enhances antibacterial activity by destruction of biofilms. Now, biofilms are a concentrated layer where a lot of bacteria are residing. Now, clarithromycin destroys the biofilm so it can enter and destroy. Special effects of clarithromycin are it downregulates release of pro-inflammatory cytokines, increases Th1 Th2 ratio by reducing interleukin 4 and interleukin 5, It inhibits the production of bacterial adhesins and inflammatory toxins. So with all these special effects, and it has a huge distribution, it goes and acts in a lot of areas. It has higher bioavailability than erythromycin. And a special effect is it accumulates in the lung tissue and alveolar macrophages in higher concentration than serum. So it has specific role in lung disorders. It improves the mucociliary clearance, it improves ciliary movement, suppresses mucus production. So with all this added advantage of clarithromycin, it is a wonderful drug. So in a patient with atypical pneumonia, in outpatient basis, with or without prior exposure, clarithromycin is the drug of choice. In inpatient therapy, since you cannot use and the patient is a sick patient, you take beta-lactam plus clarithromycin. So what they did was clarithromycin with compared to other macrolides, clarithromycin is much safer. Also, it is much more effective than erythromycin. So finally, to summarize, atypical community acquired pneumonia is a common respiratory infection in Indian population. Mycoplasma is the most common. They are all resistant to beta-lactams, and you cannot use fluorocurans because of it is a reserved drug for tuberculosis. Clarithromycin is beneficial in treatment of atypical community acquired pneumonia, provides enhanced antimicrobial activity. So clarithromycin is recommended for treatment of atypical pneumonia, either as monotherapy or in combination therapy. So I would like to thank you and enhance the point that invariably most of the upper respiratory infections are viral in origin. Very few are bacterial in origin. It is essential for us to understand what are the ones which are bacterial in origin. Whenever treating a bacterial origin infection, we have to aim at eradication, make sure we give the complete course, and whenever possible, identify those which are resistant to amoxicillin and choose clarithromycin is as your second line drug. I hope it was informative. I thank the organizers and all the participants who have listened to the lecture. Thank you.
Hello.
Hello.
Thank you, sir. It was a very good presentation, a wonderful oration by you. And you have also added very good insights apart from the presentation with the demonstration of such indications also. It was really a very nice presentation. So let's ask participants if they have any questions, we can take up one by one. Yeah, participants, if you have any questions, you can unmute yourself and can ask questions to the doctor. Because I don't see any questions in the chat box. So you can unmute yourself. No, the audio isn't. So there is an option next to your mute button. Yes, now it's audible. Yes.
Can you hear this?
I can hear you, not the video, sir.
Is it? How to make the video?
Okay. So there is an option next to mute button.
Yeah.
Yeah. So there is an option where you can see same as system. Select a microphone, same as system.
Now? Can you hear now?
Yes.
So this is croupy cough. So, something like a barking nature. And this is whooping cough.
No, the voice is gone again.
ಸೌಂಡ್ ಬರೋ ಅದೇ ಹೇಳ ಸೌಂಡ್ ಬರೋ
Okay. So I think we are done.
Okay. Yeah, any questions from the audience? Yeah, there's someone, Dr. Chopade.
No, I will see.
So do you want to ask a question?
No.
Okay. So currently we don't have